400 IU or 800 IU? To supplement on demand or to supplement regularly? Such are the questions which today's pediatricians are really plagued, and the parents are also asking a lot of questions about vitamin D and the supplementation status for their kids. Good afternoon one and all. I am Dr. Rahul Joshi, Medical Lead for Sanofi Consumer Healthcare, and I invite you for a very elaborate academic feast on vitamin D, and especially the topic for today is the physiological benefits and how nanotechnology at the cutting edge helps our own pediatric age population to really tackle the issue of vitamin D supplementation. And to take us all through this, we have a very prominent and a very eminent personality in pediatric endocrinology, none other than Dr. Professor Abhishek Kulkarni. Sir is an honorary consultant and department coordinator. He is also an honorary consultant, PD Hinduja Hospital, Apollo, Navi, Mumbai. He heads the pediatric and adolescent endocrinology in T2T Hormone Clinics, India. Sir is a scientific national convener, academic of Indian Academy of Pediatrics, congenital hypoparathyroidism. His affiliations also span to the national plan of 2019 to 2020. He is program in charge and postdoctoral fellowship in pediatric endocrinology and SRCC. There are several publications under his belt, and not just in reputed Indian but also in international journals. There are a lot of books which are being published. He is also presented in multiple forums, national, international. He is always invited as an expert, which we have today as well, to throw more light on what is status of vitamin D supplementation in kids. His special interest lies in, as you all know, glucochronology and also in vitamin D research. With that, let us put a huge round of applause and invite Dr. Abhishek Kulkarni. Sir, over to you.
Good afternoon, colleagues. A topic which merits discussion, often quotes controversies, but most importantly requires unambiguous take-home messages and guidelines from the pediatrician in the best interest of the child. Vitamin D deficiency, current consensus on diagnosis and management. The presentation is going to be based on the following outline. I will touch upon the statistics of vitamin D deficiency in our country, the varied presentations of vitamin D deficiency which pediatricians must be aware of, the revised classification to avoid the ambiguity in the mind of the pediatrician as to what constitutes deficiency, the population of children who should be screened for vitamin D deficiency, our strategies which could help prevent vitamin D deficiency, the revised guidelines for treating the same, a quick word on the plausible extraskeletal benefits of vitamin D supplementation, a slide or two on preparations available in our country and how does the pediatrician make a choice between the basket to the best interest of the patient, and a last slide to sum up what I'm going to be speaking in the next 35 or 40 minutes. To begin with, and I'm not going to take too much time to explain physiology of vitamin D to my pediatrician colleagues, but to begin with, we all need to understand that sunlight and food sources are prime baskets from where vitamin D is obtained by children and adults alike. And knowing that Indians possess skin type 5, we are not very happy to rely on sunlight alone as a source of vitamin D. Kindly note the food sources that have been highlighted in the photograph are food sources which are fortified with vitamin D. Unfortunately in India, food fortification is not yet in vogue, and what is often taught to pediatric postgraduates is fatty fishes are rich sources of vitamin D. To enumerate a few, they are salmon, mackerel and swordfishes. Now, the pediatrician must understand that the salmons being sold in the Indian fish market are farm cultivated salmons which have 25% vitamin D content of the wild type Antarctic salmons. So what is published in research as to the source of rich content of vitamin D is the wild type salmon, and what is sold in the Indian fish market is the farm cultivated salmon, which has 1/4 the content of vitamin D. So in the absence of food fortification, and with the fact that we possess skin type 5, which is a poor synthesizer of vitamin D, other than food fortification, we hardly have a strategy to prevent vitamin D insufficiency. And that is the purpose of the talk today, to emphasize as to why do some children need vitamin D supplementation even in good health, and why do some need therapeutic doses to treat vitamin D deficiency. So sunlight helps us synthesize 7-dehydrocholesterol, which is photolyzed to pre-vitamin D3, which is stored in the system as cholecalciferol or vitamin D3. This is subsequently hydroxylated in the liver and secondarily hydroxylated by the 1-alpha hydroxylase enzyme in the kidney to the active form, which is calcitriol. It is calcitriol through which the biologic functions of vitamin D are exerted. The pediatrician must be aware that what is sold in the market as supplement is cholecalciferol, whereas the effector of biologic function is calcitriol or 1,25-dihydroxyvitamin D3. And what clinicians are supposed to estimate as a barometer of vitamin D stores of the child is 25-hydroxyvitamin D. So you require intact liver functions for cholecalciferol to be hydroxylated to 25-hydroxyvitamin D, and this is what is recommended to be measured as the barometer of vitamin D status of a child. Please understand, this is because the half-life of 25-hydroxyvitamin D is the longest, which is anywhere between 14 to 21 days, whereas the half-life of calcitriol or the effector form of vitamin D is only 4 to 5 hours, and hence estimation of calcitriol is not recommended in clinical practice except in special situations like resistant rickets, chronic kidney disease, hypoparathyroidism and pseudohypoparathyroidism, which are the domain best of a pediatric endocrine specialist. Just to begin with, I have quoted a study done by Marva et al. Way back in 2005, which was subsequently substantiated by many groups of researchers, that close to 90% of school children in the North Indian population had 25-hydroxyvitamin D levels below 20 nanograms per ml. And as per the current recommendations of the global and the Indian group, a level of 20 nanogram per ml and above is classified as sufficiency for skeletal health. Now this is an important point the pediatrician must note, that pediatric endocrinologists talk of sufficiency with the perspective of skeletal health in mind. We do not have data robust enough for us to derive sufficient levels for extra skeletal benefits. So we must not extrapolate the number of 20 to the human body as such, but limit it to the skeletal benefits of vitamin D on the human system. So this is the first take-home message for the pediatrician, is all that the pediatric endocrinologist speaks of is skeletal health and vitamin D levels. So this was subsequently substantiated by Puri et al. That close to 90% of school-going children in North India had levels less than 20 nanogram per ml. And this is what should get the pediatrician worried, is your school population is vitamin D deficient. Most mothers, which is 81 to 84% in studies again coming from North India, one done in SGPGI Lucknow, the second one done by Vandana Jain et al. At AIMS, signified close to 80 or even up to 85% in one cohort mothers were vitamin D insufficient. There is significant correlation between maternal vitamin D status, cord blood 25-OHD and subsequently neonatal 25-hydroxyvitamin D levels. And to add to the insult, breast milk, which is promoted and rightly so by the pediatric fraternity, is an extremely poor source of vitamin D, levels varying between 20 to 60 international units per liter based on the population studied. This is just to emphasize the correlation between maternal vitamin D deficiency and the deficiency existing in neonates. So in a study done by Seth and Marwa et al., again from Delhi, 60% of infants were found to have vitamin D levels of less than 10 nanograms per ml when mothers had 25 OHD levels of less than 10, whereas if mothers had 25 hydroxy vitamin D levels of more than 10, the number of infants with severe vitamin D deficiency was reduced to half, highlighting the fact that there was significant correlation between maternal, cord and subsequently neonatal 25 hydroxy vitamin D levels. Once we've highlighted the statistics and the prevalence of vitamin D deficiency and insufficiency both in our pediatric population, I'm going to touch a few slides on the varied presentations that the pediatrician must keep in mind for diagnosing vitamin D deficiency. However, before I begin presenting this slide, the pediatrician must be aware that the commonest presentation of vitamin D insufficiency or deficiency could be an asymptomatic individual detected on screening. So every pediatrician would be aware of this case profile of a child coming with wrist widening, bowing of legs, exhibiting rachitic rosary and elevated alkaline phosphatase levels. So rickets is the commonest, or rather vitamin D deficiency is the commonest cause of rickets, and in our population it is usually a combination of vitamin D and calcium deficiency. Every pediatrician would be and must be aware of this manifestation or presentation of vitamin D deficiency. Now I'm going to talk of a few atypical presentations of vitamin D deficiency which the pediatrician must be aware of. A newborn or a young infant landing up with tachycardia, signs of cardiac failure, X-ray and 2D echo demonstrating a picture of dilated heart and dilated cardiomyopathy respectively, one must look at serum calcium levels. Again, the pediatrician here needs to understand that this is an extremely rare manifestation of vitamin D deficiency, but it has been taken into account to emphasize that severe vitamin D deficiency leading to hypocalcemia could be a reversible cause of dilated cardiomyopathy. I do not wish to emphasize that hypocalcemia is a common cause of dilated cardiomyopathy. It isn't. But the pediatrician must remember that it is one of the reversible causes of dilated cardiomyopathy. I'm going to share here a case of an adolescent who was referred to me to evaluate him for multiple fractures by the orthopedic surgeon. And this is how his X-ray looked like. The X-ray depicted a pseudo fracture picture in the left pubic ramus, and when we evaluated this adolescent with a bone scan, we found evidences of pseudo fractures in the entire skeleton, making us, or rather foxing us, to think that were we dealing with polyostotic fibrous dysplasia. But to our surprise, in this individual the vitamin D levels were undetectable, and we decided to supplement vitamin D to this individual in therapeutic doses and follow up on the alkaline phosphatase 12 weeks later, which had remitted to levels below 450 IU per liter. And on repeating the bone scan 12 weeks or 12 maybe 16 weeks later, all of the increased uptake in the metaphysis and pseudo fractures had vanished. So this is again one of the extremely rare presentations of vitamin D deficiency, which is severe osteomalacia manifesting as pseudo fractures leading to significant dilemma in the minds of the orthopedician and the pediatric endocrinologist. This is just to emphasize one of the presentations of severe vitamin D deficiency is late onset hypocalcemia and hypocalcemic seizures. This study emphasizes that hypovitaminosis was observed in close to 90% of the study group, which is infants who presented with hypocalcemic seizures, and the mean 25-hydroxyvitamin D level was significantly lower in all the subjects in the study group. Again, the study emphasized that there was significant correlation of neonatal 25-hydroxyvitamin D levels with maternal levels. So the take-home message for the pediatrician is the pediatrician must evaluate infants who present with late onset hypocalcemia for vitamin D deficiency. And the strange differential finding biochemically in this set of patients is serum phosphorus levels could be elevated in contrast to the usual low serum phosphorus levels which we see in patients with vitamin D deficiency due to secondary hyperparathyroidism, but paradoxically in infants we see higher serum phosphate levels in severe vitamin D deficiency leading to hypocalcemia. So this is something the pediatrician must be aware, and he must take it in his stride that vitamin D deficiency in early infancy could be associated with high serum phosphate levels, because the usual teaching is vitamin D deficiency leads to secondary hyperparathyroidism leading to hypophosphatemia, but that could not be the case in early infancy due to changes in tubular sensitivity to phosphorus and the action of parathyroid hormone. Impact of vitamin D deficiency, I have already spoken about it. What has conclusively been established is correlation and cause and effect relationship between maternal, cord blood and neonatal serum 25-hydroxyvitamin D levels leading to rickets and neonatal hypocalcemia of the late onset variety. What is yet postulated but for which evidence is not robust enough is whether vitamin D deficiency leads to lesser femoral bone development as early as 19th week of pregnancy. And if you look at the slide carefully, I have put 3 question marks at the end of the statement, because after reviewing a good set of papers, I wasn't convinced enough that vitamin D deficiency was linked or causative with regards to femoral bone development in the fetus. So currently we could label this best as association rather than cause-effect relationship. And another point often spoken or postulated about is, does maternal vitamin D deficiency lead to lower neonatal birth weight? And the answer again is there is no data robust enough for us to conclusively link or negate the two. So at present, both these hypotheses are best considered plausible or postulated and left alone. So let's come to define vitamin D sufficiency now, and these are the questions which a researcher often poses to himself before deciding on a numerical cutoff to recommend to the clinician. What level of vitamin D do we consider sufficient? Is it the level below which PTH starts to rise? Is it the level at which fractional absorption of calcium is the best? Is it the level at which bone density is the best optimal? Is it the level at which adverse effects like fractures, falls, muscle strength are reduced? Or is it the non-skeletal effects, the evidence for which is weak as of yet? Or is the answer to all of this is all of the above? So let's clarify this. Now these are cutoffs recommended by the Global Consensus Recommendations Group on Prevention and Management of Vitamin D Deficiency Leading to Nutritional Rickets. And let me emphasize again that as pediatric endocrinologists, we talk of vitamin D sufficiency in relation to optimal bone health. data is not robust enough for us to recommend 20 nanograms per ml as a cutoff for plausible extraskeletal benefits or health due to vitamin D sufficiency. So the current recommendations state that for optimal skeletal health, a vitamin D level, a 25 hydroxy vitamin D level of greater than 20 nanograms per ml is sufficient. Levels between 12 and 20 are classified as insufficient, and levels below 12 are classified as deficient. For toxicity, a ceiling of 100 nanograms per ml has been defined. However, pediatricians are recommended not to exceed 70 nanograms per ml of 25 hydroxy vitamin D level in the pediatric population. Now, how do we differentiate insufficiency from deficiency? This is a question commonly asked by my pediatrician colleagues, and the answer is levels below 12 nanogram per ml have higher incidences of rickets. So the terminology deficiency as per this classification implies to the rachitic threshold, whereas levels between 12 and 20 have the population with higher parathyroid hormone levels, and hence these levels are classified as insufficient. Levels above 20 nanograms per ml are associated with normal parathyroid levels in the population and hence are classified as sufficient. This goes to show that the current cutoffs and recommendations are based purely on skeletal health of the child and the adolescent, and no other factor has been taken into consideration while determining these cutoffs. So, quick word on prevention of vitamin D deficiency. Are we going to achieve it through sunlight exposure? Are we going to achieve it through supplementing infants and maybe children? Are we going to achieve it by supplementing expecting mothers? Or is food fortification the only way forward? India did attempt food fortification. A study done by Khadgawat and Marwa et al. In Delhi demonstrated that 70% of adolescents, and in a cohort where higher doses were used for supplementation, 80% of the adolescents achieved sufficient levels of vitamin D when they were supplemented with 600 and 1000 IU per day of vitamin D respectively in each group, vis-a-vis the levels which they had at baseline. So this just goes to highlight, and this was done through milk, assuming that the adolescents would consume anywhere between 3 to 500 ml of milk. So it was fortified milk which was introduced into two sets of study groups, and their vitamin D levels compared versus those at the baseline. So this is to emphasize that food fortification is the easiest and the surest way, because it obviates the confounding factors which come through sunlight while relying on it as a source of vitamin D synthesis or source of vitamin D production. Which children do we screen? Do we screen all pediatric population for vitamin D deficiency? And the answer is unequivocally no. There is no recommendation as of yet to screen asymptomatic children for vitamin D insufficiency or deficiency. This is the group I could best delineate from current literature to make a recommendation as to whom do we screen for vitamin D insufficiency and deficiency. The first, children with malabsorption, pancreatic insufficiency, inflammatory bowel disease, hepatobiliary disorders, and patients post bariatric surgery. Children who are on anticonvulsants, glucocorticoids, antiretroviral therapy, and rarely ketoconazole. So patients who are on any of these group of drugs must catch the eye of the pediatrician for prophylactic screening and supplementation. A child who's had rickets in the past definitely merits prophylactic screening and continued supplementation for prevention of a relapse of vitamin D deficiency. Children who have chronic kidney and liver issues, obviously for the need of hydroxylation of cholecalciferol to its active forms. Children who visit the endocrine clinic particularly those with hypogonadism or steroid excess, because these conditions predispose you to suboptimal bone health and metabolism. Transplant recipients and children on treatment for malignancy. So it's a simple add-on that children visiting the hematology and oncology unit do get prophylactic vitamin D screening, and if resources are a constraint, at least maintenance vitamin D supplementation. With the increasing advent of adolescent obesity, pediatricians must be aware that the least they could do for obese adolescents, in addition to counseling them for appropriate lifestyle, is supplement vitamin D in physiologic or maybe even up to twice the physiologic recommended doses as per their age groups. And children visiting the pediatric neurology outpatient, especially those with physical disabilities and who lack exposure to sunlight and the ones who are immobilized, must be prophylactically screened and supplemented with vitamin D. This group is no different. There is a significant overlap between the two. But the take homes from this slide is universal vitamin D supplementation in infancy is recommended as a norm. For populations who are at higher risk of vitamin D deficiency, it is desirable but not mandatory to continue supplementation in the first 2 or maybe even up to the end of 3rd year of life. There is a significant controversy whether recommendation of supplementation could be extrapolated to the adolescent population universally, or should it be based on the risk stratification that the population is exposed to. So this is just to emphasize to the audience that skin type, sunlight exposure, clothing, confounding factors, most importantly the race, plays a huge role in endogenous vitamin D synthesis in the population. This is how South Asians were supposed to be, and currently you can see all of us are clothed, well clothed and indoors during the mid-noon, which is 10 a.m. to 3 p.m., which is the best time for synthesis of vitamin D deficiency in the skin. Most of us are indoors and so are our children, and you realize that the time of sun exposure recommended is twice or maybe even up to 3 times in South Asians than that of Caucasians, emphasizing why we need to rely on food fortification and prophylactic supplementation. So this is a study done from Pune by Patwardhan et al., which emphasized that, or rather substantiated the fact that as South Asians we require 1 hour of casual midday sunlight exposure. When I say midday, please understand it's 10 a.m. to 3 p.m. to achieve sufficient vitamin D levels. And the study was impressive because they had quantified standard erythema dose instead of using a subjective parameter, which is the minimal erythema dose. The pediatrician needs to understand that we have replaced the concept of minimal erythema dose, which is liable to individual sensitivity to ultraviolet radiation, with standard erythema dose. So the study was conducted very professionally, where individuals were made to wear dosimeters, and these dosimeters were outsourced to the bone clinic in the UK, and the effective radiant exposure was quantified in units of 100 joules per meter square. And based on extrapolation of this energy data, a number of 1 hour per day was derived to achieve sufficient levels of 25 hydroxy vitamin D in the population. So this is probably the best study from India which provides us with objective number of 1 hour of midday sunlight exposure with 15% of the body surface area exposed to achieve sufficient levels of vitamin D. And this seems a bit difficult because during the midday most of us are well clothed and indoors. We also need to quickly understand that there are a host of confounding factors which impact vitamin D synthesis. Most importantly, the wavelength of the ultraviolet light hitting the skin at the zenith angle. In urban India, where sunlight is reflected from walls of buildings, achieving 290 to 315 nanometers is actually difficult. Asians, especially Indians, possess skin type 5, which is the second worst synthesizer of vitamin D after skin type 6. Solar noon, which is midday, renders most of us indoors in office or at home. Seasons, winters lead to 80% or maybe even up to 100% reduction in places where winters are harsh in vitamin D synthesis. Cloud cover, water vapor, industrial pollution, use of sunscreens, clothing and indoor habits obviously confound synthesis of vitamin D in populations. So who needs treatment? Now let's get to treatment quickly. Is the pediatrician needs to understand that emergency presentations of hypocalcemia like seizures and cardiac failure require hospitalization, use of IV calcium gluconate and addition of the effector form of vitamin D, which is calcitriol, for the first 4 to 7 days to achieve quick results and reduce dependency on IV calcium. Now this is a very important take-home message, that in the ICUs, in addition to supplementing IV calcium, pediatricians must ensure the use of calcitriol or the effector form of vitamin D to quickly build up serum calcium levels and reduce the reliance on IV calcium after the first 48 hours. Children presenting with clinical and biochemical features of rickets must obviously be treated with a combination of vitamin D and calcium, whereas those detected to have low vitamin D on screening must be supplemented with vitamin D alone, ensuring that 500 to 600 milligram of elemental calcium is derived from dietary sources in them. Treatment protocols, again, this needs to catch the eye of the pediatrician. High dose TOS therapy with doses as less as 3 lakh units have been associated with hypervitaminosis D in infants. We are not even discussing 6 lakh units in the current modern era. Lower doses are effective in treating rickets without causing toxicity. Only cholecalciferol, that is vitamin D3, is available for treatment of vitamin D deficiency in India, though this is soon to change. There are preparations of vitamin D2 coming into the market. There is limited evidence to support superiority of one particular regime over the others. You may choose to follow the daily, intermittent or single dose therapy based on your suspicion of compliance ability of the patient. In general, healing of rickets occurs over a period of 8 to 12 weeks, and the pediatrician must not hurry to retest the patient prior. The goal of treatment is to achieve healing with adequate doses of vitamin D without causing the risk of hypervitaminosis D and hypercalcemia. So the recommendation from the global consensus group is that in infancy, you supplement 2000 IU of vitamin D every day for a total duration of 12 weeks. After infancy, up to the age of 12, you supplement 3 to 6000 units of vitamin D daily for a total duration of 12 weeks. And after the age of 12, you supplement 6000 international units of vitamin D daily for a total duration of 12 weeks. Please understand, the global consensus group does not talk of intermittent or weekly doses of vitamin D for treatment of nutritional rickets. It either talks of daily supplementation or then it talks of single dose TOS regime, but please look at the numbers. In infancy, beyond the 3rd month of life, you supplement only 50,000 international units, one single dose. In childhood, you supplement 1,50,000 units, one single dose, and in adolescence, you end up supplementing 3 lakh units, one single dose. Please look at the column on the extreme right, which says subsequently continue maintenance doses of vitamin D to prevent a relapse of rickets in this population. Now, what does the Indian Academy of Pediatrics recommend? The Indian Academy of Pediatrics guidelines seem a miniature extrapolation of the global consensus group recommendations. The only difference being the one that I have highlighted in the box is Indian Academy of Pediatrics does recommend the use of weekly doses of vitamin D for 6 weeks after the age of 3 months, right up to the end of adolescence. So the concept of intermittent dosing for treatment of vitamin D deficiency and combination rickets does exist in the recommendations of the Indian Academy of Pediatrics. But understand the difference is when you do supplementation daily, you treat the infant, child or the adolescent for a total duration of 12 weeks, whereas when you use intermittent dosing as the one recommended by Indian Academy of Pediatrics, the total duration of therapy is 6 weeks, after which the child or the adolescent is switched over to maintenance doses of vitamin D. The other important take-home message from the slide is supplementation of calcium is ubiquitous while treating nutritional rickets, whereas it is through the dietary sources where a recommendation of 500 to 600 milligrams of elemental calcium is made while treating asymptomatic vitamin D deficiency. Supplementation of calcium is not recommended through pharmacotherapeutic sources while treating asymptomatic vitamin D deficiency. Now a quick word on potential non-skeletal functions of vitamin D. Researchers have attributed benefits of vitamin D to functions like innate immunity, immunomodulation, blood pressure regulation, blood sugar control, and even protection or prevention of malignancies. So it would soon seem that vitamin D is going to be the one-stop pill for longevity. But is it so? And I'll try to clarify to the audience as to what is the current position of extraskeletal benefits of vitamin D. Let's talk of cardiac, because this is what interests physicians the most, and vitamin D is postulated to downregulate renin, reduce pro-inflammatory markers and smooth muscle proliferation. So logically it should be beneficial in cardiac health of individuals. But what does current evidence say? A meta-analysis of 51 randomized control trials shows us that vitamin D has not been associated significantly with any of the parameters, including myocardial infarction, stroke, death or blood pressure. So I leave it best to the audience to decide whether this is a hope or a potential hype. Talking of diabetes, an area of interest to the pediatric endocrinologist, and there is some recommendation that I can make from the TEDdy trial, and that is lower vitamin D levels do predict islet cell autoimmunity in children. So this is a fact that vitamin D deficiency does predispose children to islet cell autoimmunity, but the caveat is these children must be homozygous for minor variations in the vitamin D receptor. They must be homozygous for receptor alleles, that is vitamin D receptors must depict homozygous polymorphisms for vitamin D deficiency to act as one of the triggers of islet cell autoimmunity. So the take-home message from this slide is genotype rather than vitamin D deficiency is more a predictor of islet cell autoimmunity in children. But yes, I agree, vitamin D deficiency does aggravate the genotype further by environmental predisposition. A quick word on asthma and vitamin D is results show that children with bronchial asthma again are often accompanied by different degrees of vitamin D receptor gene polymorphism. So please understand it's the genotype on which vitamin D deficiency works to predispose children to asthma, like in islet cell autoimmunity. So two of the most studied conditions, type 1 diabetes mellitus and asthma, vitamin D deficiency becomes significant if these children have vitamin D receptor polymorphisms. And publication from our own Indian pediatrics suggests that vitamin D deficiency could be an important factor influencing asthma control, especially if they have genetic polymorphisms in the vitamin D receptor gene. So this is something where we could say there is evidence to associate and correlate vitamin D deficiency with predisposition to disease and therapeutic outcomes. Coming to cancers and immunity, the level of evidence currently is insufficient for us to make any recommendation, whereas with regards to immunity, the evidence is only limited to animal models, and human data, the evidence is currently best epidemiologic and nowhere clinical for highlighting the importance of vitamin D in immune health. So the last aspect of my presentation is the type of preparation the pediatrician must choose from the armamentarium that is currently available in the Indian pharmacopoeia. And again here I would like to use a study done by my colleague Khadgawat et al. From All India Institute of Medical Sciences, which emphasized that only a third of the preparations or formulations available in the market had the accepted range of cholecalciferol within them. And look at the staggering variation amongst the commercial preparations. It went on from minus 91% to a plus of 65%. So you could be both potentially under-treating or creating iatrogenic vitamin D toxicity if your preparation is not well standardized and validated. The factors which influence the choice of preparation by a clinician are the absorption, the bioavailability of the preparation, and the ease of administration and the surety of compliance. And this is where preparations using the nanotechnology or micellization score over the conventional preparations which have been marketed as till date. So conventional preparations do require a high fat medium to ensure appropriate absorption, whereas those prepared from micellization do not require a high fat meal or a medium. Bioavailability depends on bile secretions, micelle formation and diffusion through the unstirred water layer in the gut. And compliance definitely does become an issue when the conventional preparations mandate a glass of milk or a spoon of clarified butter to be taken along, whereas those with nanotechnology could just be consumed by themselves or with water. Now this is again a study done by Marva et al. Which emphasized that preparations which are prepared by the nanotechnology or are micellized did achieve better vitamin D levels in the study cohort versus those using the conventional preparations that were available in the Indian market till the recent past. And based on some extrapolation data, the group also postulated that the micellized preparation probably were absorbed close to 35% better than the conventional preparations. If you read this paper carefully, there were a few confounding factors like vitamin D levels at the baseline, but the researchers postulated that these differences were insignificant and could not have impacted the final outcome of the study. So to sum up, the convenience of preparations manufactured by the nanotechnology or micellization, as they call it scientifically, is absorption is independent of the amount of fat in the gut. This is the single most important advantage, that you do not require a fat medium to ensure appropriate absorption of this vitamin D preparation. The formulations are highly palatable and are available in the form of ready to drink shots or powders. The results are equivalent when studied both in the fasting or in the fed state. So we do not need to provide instructions to the parent with regards to the timing of consumption of the supplement. So my friends, my take-home messages after today's presentation are: vitamin D deficiency is extremely common in Indian children and adolescents. Apart from rickets, which most pediatricians are aware of, vitamin D deficiency is an important cause of late onset hypocalcemia and calcemic seizures, osteomalacia, and extremely rarely dilated cardiomyopathy. 25-hydroxy vitamin D must be used as a barometer to assess the vitamin D status of an individual. We do not use calcitriol for estimating the vitamin D reserve of an individual except in certain rare circumstances in conjunction or under the supervision of a pediatric endocrine specialist. The measures of sufficiency, deficiency and insufficiency have been redefined and revised, and new treatment protocols have been suggested both by groups globally and locally. Screening and supplementation of vitamin D must be prophylactically performed for high-risk groups, and currently data is not robust to recommend uniform screening and supplementation of children and adolescents in general. While the skeletal benefits of vitamin D supplementation have been unequivocally established, the other postulated potential benefits mandate larger and robust subsequent evidences. Thank you very much.
Thank you so much, sir, for a very elaborate talk. And to follow the talk, we have a lot of questions coming in from all across the country. And as you can see the dashboard here, so I'll take this. So there are a lot of questions which are already been answered by Dr. Kulkarni, and as you can see from the slide deck as well, which was telecasted. So I'll take those peculiar ones which need a little bit of more explanation for the larger audience. So Dr. Sarla wants to know, if I have to refer as a quick handy reckoner, which is the best guideline to go to from an Indian perspective?
So from the Indian perspective, I could happily recommend that we look up to the guideline recommendations of the Indian Academy of Pediatrics group, and the guideline very categorically differentiates supplementation in infancy to, or rather treatment of vitamin D deficiency, to that done in the first 3 months of life and then subsequently in the later part of infancy. So that's the only caveat that this guideline possesses, is it makes a recommendation on intermittent supplementation of vitamin D, which all of us have routinely practiced during our training and subsequently practice days. So for the Indian setting, I would recommend the Indian Academy of Pediatrics guideline, but pediatricians must be closely aware of the global consensus recommendation group, because the Indian group was a part of preparing the global consensus group recommendation.
Okay. Dr. VP Suren, he wants to know that is it required to supplement vitamin D3 in kids below 1 year?
Yes, so this is something ubiquitous, and I'm happy to make a recommendation that most endocrine societies recommend universal supplementation of vitamin D in a dose of 400 international units per day, irrespective of the modality of feeding in infancy. So this is a simple take home for the pediatrician, is every infant must be receiving supplementation with 400 international units of vitamin D, irrespective of the modality of feeding being offered to the infant.
Okay. Dr. Abhijit Agarwal wants to know, is there a particular time of the day when we should prefer doing serum calcitriol level in specific cases like you have already mentioned, since the half-life is 4 to 7 hours? So any period of day?
Yes, so Dr. Agarwal, the answer to your question first is I would not recommend doing calcitriol levels routinely in pediatric population, except a set of patients like chronic kidney disease, resistant rickets, hypoparathyroidism and pseudo-hypoparathyroidism. And the answer to your part of the question, that is there a specific time, rather than the timing of the day, we would be interested in the time lag between the collection center and the processing unit. Going by the half-life of the molecule to be estimated, I would recommend a transport time of less than 60 minutes in your setting. So if your place is more than 60 minutes away from the processing unit of 125 dihydroxy vitamin D, I would not recommend you to be collecting sample for calcitriol estimation. The patient must be shifted to the processing unit for collection, all the necessary prerequisites be due followed, and only then the sample be collected and estimated.
Okay, so that's there you go. That's a very elaborate response. Dr. Ronak also wants to know that I have seen a few brands in the sublingual which come with the sublingual vitamin D patches. Again, so is it physiologically rational? How do it work really in the body?
So this is something that the group is currently studying in. Sublingual patches of vitamin D currently are not studied in the pediatric or adolescent population. They are also based on the principle of micellization like the current available commercial preparations are, but their absorption is highly variable and we need better data for us to quantify them in terms of equivalence to oral preparation. So the answer to your question is, till we have better data on equivalence of 25 hydroxy vitamin D levels in randomized or non-randomized prospective control studies, it would be best to refrain from using them in pediatric or adolescent population.
Okay. Dr. Brij Gopal Bhargav wants to know any prophylaxis D3 schedule for adolescent.
Yes, so here the global consensus group and the Indian group differ significantly, because there is a recommendation by a part of the global consensus group of supplementing adolescents anywhere between 6,000 to 1,000 international units of vitamin D per day based on the ethnicity of the adolescent. Whereas if you read a recent publication in the Indian Pediatrics, again by Seth et al., it questions this recommendation and wishes to make supplementation based on certain risk factors which I had highlighted during my presentation. So as of now, the recommendation that I would like to make is supplementation in the adolescent group be best done on a case-to-case basis, ascertaining whether the individual is exposed to sunlight for an hour during mid-noon and whether the individual could derive vitamin D from dietary sources, or whether the individual is consuming food which is fortified in vitamin D. And if the answer to these three questions is no for you, then you have every right to supplement this adolescent with doses between 600 but surely not exceeding 1,000 international units per day.
Okay. So there are plenty of questions coming in, but I'll take a few which are of the lot. There's another question on supplementation again, apparently. How long do we supplement a kid? So if you start in infancy or neonatal age, do we give them till they are toddlers or till 5 years?
Yes. So globally the recommendation is to continue supplementation till the first birthday. But when you look at specific skin types, that is skin type 5 and 6, of which we are skin type 5, Professor Hollick made a recommendation that supplementation be best continued till the end of 3rd year of life. And this is because incidence of rickets is higher till the end of 3rd year of life in the population in the subcontinent. So till the end of 1st year, definitely, and depending on how high risk your population is, prophylactic supplementation could be continued till the 3rd year of life, but this will have to be customized individually.
Dr. Mohan is asking whether we have to repeat D3 levels after completing 8 doses of STOS therapy.
Yes, so it is currently 6 doses of intermittent vitamin D supplementation or a single dose STOS therapy based on the age group. And the recommendation is to look at the alkaline phosphatase at the end of 12 weeks. The only setting where you would repeat 25 hydroxy vitamin D level is a setting where you suspect malabsorption or your patient in question has chronic liver disease. In these two conditions, you are allowed to repeat a measurement of 25 hydroxy vitamin D level. Otherwise, the cheaper surrogate is to use alkaline phosphatase at the end of 12 weeks, document a decline, and happily assume that your vitamin D deficiency has been treated.
Okay. Dr. Sumit Kumar wants to know which one is a better option for a neonate supplementation: 400 unit of cholecalciferol or serum calcium phosphorus, or both in syrup?
Yes. So now recommendations from the expert group both globally and in India are supplementation of 400 international units of vitamin D. While I agree that most pediatricians do add a calcium preparation as supplementation to infants, this decision is best based on their analysis and thought process of the amount of calcium the infant is receiving from breast milk or the formula. The expert group on vitamin D does not make a recommendation of calcium supplementation in infancy. What it says is an infant must derive up to 260 milligrams of calcium from his or her feed. So it does not make a recommendation of supplementing calcium universally in infancy.
Okay. Dr. Neeta Kejriwal, she wants to know that if an infant is on a top feed for up to 1 liter per day, is there a need to supplement?
Yes, so this question again was taken into account while making a universal recommendation for supplementation of vitamin D in infancy, and the answer is yes. In spite of the infant being on formula, the recommendation is to supplement 400 international units of vitamin D. And if you look at it logically, the suggestion is appropriate, as your formula would provide about 400 international units per liter. And if you do not exceed 600 international units of vitamin D supplementation, you do not exceed the upper ceiling of 1000 international units of vitamin D, which is recommended in infancy. So you're safe in supplementing 400 international units of vitamin D, and the confounding factor here is the infant is expected to consume 1 liter of formula every day, which may not be a reality. So it's best recommended to supplement 400 international units of vitamin D in infancy, irrespective of the modality of feeding being followed.
Okay. We have also some compliments which are coming in. Dr. Bhanudas says, congratulations Dr. Abhishek, thank you for the lucid talk, cleared all the doubts.
Thank you.
Right. We go to the next question here by Dr. Salil Choksi. He says, if a child has not received regular supplementation, should be the level tested when we start with treating the deficiency, if it is documented, or we start correcting, or we start supplementing right away?
So it depends on how have you made the diagnosis of vitamin D deficiency. If you are treating rickets, in the modern world it would be recommended to test the 25-hydroxy vitamin D levels, not only to quantify the degree of deficiency, but also rule out differential diagnosis if your vitamin D levels are sufficient. Similarly, if you encounter a child with hypocalcemia, it would be strongly recommended to test a 25-hydroxy vitamin D level. However, when vitamin D is prescribed for vague aches and pains, as it is a common practice in the pediatric population, supplementation of more than 1000 international units per day is not recommended. If the clinician wishes to supplement more than 1000 international units per day in any setting, testing 25-hydroxy vitamin D level is strongly indicated.
Okay. So I think let's take a couple of more questions and then we call it a day for us.
Surely.
Right. So Dr. Sanjeev Ahuja is asking, do you recommend 800 or a higher dose of routine maintenance in preterms and LBW kids?
So while I agree the older recommendation was to supplement 800 international units of vitamin D in preterm infants, the current recommendation is to supplement between 4 to 800 international units per day in the preterm neonate. Doses above that have been associated with hypercalciuria and vitamin D levels of more than 70 nanogram per ml in the neonatal period, and hence I would not be in a position to make a recommendation of universal supplementation of doses more than 800 international units per day in the premature newborn. However, if we are talking of treatment of vitamin D deficiency, as in cases of osteopenia of prematurity, the recommended doses are 1000 to 2000 international units per day. So supplementation, the ceiling should be 800 international units per day in the preterm newborn, whereas for treatment of preterm newborns for vitamin D deficiency, as in osteopenia of prematurity, the dosage regime is varying between 1000 to 2000 international units per day, and both groups, the global and the Indian Academy of Pediatrics, categorically mention that below 3 months of life postnatal, we should not be using intermittent or STOS based therapy for treatment of premature newborns.
All right. So that brings to the last question of the day, and why not talk about toxicity a little bit. Yes. So they are asking, Dr. Jignesh Thakur wants to know how to monitor for vitamin D toxicity in kids.
So the single most important test which the pediatrician could utilize is serum calcium levels and urine spot calcium and creatinine levels. Why I'm saying that is, even if your patient has vitamin D levels in excess of 70 nanograms per ml, what the clinician is worried about is hypercalcemia, hypercalciuria and nephrocalcinosis. So as a surrogate marker, the pediatrician, if he or she suspects that there has been a setting of vitamin D toxicity or the therapeutic guidelines have been vitiated, he or she could use serum calcium levels, keeping the half-life of the preparation used in mind. So if you've used the intermittent weekly regime, you would like to monitor the serum calcium levels up to a time period of 4 half-lives, which is 8 weeks after the last dose has been consumed. Whereas if you've injected the child with a STOS dose like 3 lakhs or 6 lakh units, which is criminal in the current medico-legal era, is you would have to monitor this particular child for 4 half-lives of 2 months, which is for a total time duration of 8 months. And all that you need to do is have a look at serum calcium and urinary calcium creatinine ratios.
Okay, all right. I think we all must agree that we have learned a lot. That was a great revision of sort, and we also got to know the recent advances as far as how the evidence-based approach medicine with respect to vitamin D is concerned. Again, I would like to profusely thank Dr. Abhishek Kulkarni for taking some time out from his busy practice to come and deliver this wonderful talk. And thank you all for joining in and asking really relevant questions. Please do continue asking questions. We'll try and answer all of them. Try and do that as the time proceeds ahead. Thank you so much. We will announce that the webinar is now ended. Thank you.